Hello everybody, welcome to our Level 1 Physical Development Training session that we're having to record for you today. So hope that you find this enjoyable and we'll hopefully get to see lots of your faces soon when we're back in the schools. So my name's Emma Paskett and I'm a TIS physiotherapist at Manor Green Primary School and Manor Green College, and my colleague Louisa Thorpe is the occupational therapist at Manor Green Schools.
And I'm Cheryl Pretty. I'm the physiotherapist based at QE2 School and Woodlands Mead School. And Susanna Engelman is the occupational therapist also based at QE2 School. The Therapies in Schools team was established off the back of a pilot that was carried out in coastal schools down in Worthing. And the model of the Therapies in Schools service delivery is that we manage a few children to do more intensive work with, be it whether they are post any type of surgery and need more intensive work, or have had a period of growth, or have a new issue that we need to address. And also part of the Therapies in Schools role is that we do teaching to all education staff for managing children with physical needs from a physio point of view, and life skills and sensory from an OT point of view, and look at doing group work within the classroom setting more than the traditional sort of therapy delivery model.
So the Therapies in Schools programme consists of 3 levels. Today we're going to be talking you through level 1 of physical development. If you find this interesting, then we can also offer you physical development level 2 and level 3. Level 2 and 3 will be hopefully done in much smaller groups, and we can get more interaction and more case studies and sort of hands-on things that we can do with you just to make it a little bit more interactive than today's session. So we're just going to show you what Therapies in Schools programme is made up of. So from the physiotherapy point of view, we will be delivering physical development training, and we will also be doing water skills training. The occupational therapist will be delivering sensory training on sensory processing and life skills training. I'm just going to talk you through the learning aims of today. So we will hope after today's session that you will have a basic understanding of typical development of the central nervous system and the peripheral nervous system. We're going to look at normal development, so infant milestones and reflexes. We want you to have a basic understanding of biomechanics, so that we'll be looking at muscles, bones and joints and how this happens during development, and we'll also be touching on muscle tone. We're going to look at altered development, so the effects that this can have on the peripheral nervous system, bone and muscle, effects on development, and the effect on our body parts. And lastly, we're going to look at orthotics, and we're going to have a look at its use and application. Okay, so first of all, we're going to look at the central nervous system. The central nervous system is made up of 2 components. So you can see from the picture on the left that it's made up of the brain and the spinal cord. The brain is one of the largest organs in the body. The spinal cord connects to the brain through the skull and is encircled by the bones of the vertebral column. It contains millions of neurons and nerve cells. The brain weighs about 3 pounds and is 15 centimetres long. And the spinal cord is on average 43 to 45 centimetres long, and both are made up of an estimated 86 billion neurons. The peripheral nervous system. So the peripheral nervous system contains all the nerves outside of the brain and the spinal cord. So take a look at the diagram. The structure coloured in pink is the brain and the spinal cord. And the the pink diagram is the brain and the spinal cord, and everything in blue is the peripheral nervous system. So this is all the nerves of the body. We have 12 pairs of cranial nerves. These come out of the brain. We have 31 pairs of spinal nerves that come out of different regions of the spine. Both sensory and motor nerves leave the CNS, and these are known as mixed nerves. So we have the sensory nerves, or afferent nerves. They transmit sensory information from the body to the central nervous system. The information is interpreted in the central nervous system, and a reaction is then triggered. Motor nerves then send this message to our muscles. So we have synapses that connect with interneurons. Synapses are really important for a reaction to occur to enable us to move our arm, to have a drink, for example, or run away from something scary. An electrical impulse must pass between nerve cells. This happens at something called a synapse. The message can then make its way to our muscles, and these impulses are able to travel at an amazing light speed. So some of these processes that happen in reflexive pain are super fast. So for example, if I was walking around the school and trod on a drawing pin, the message would travel to the spinal cord so quickly, and immediately I'd be able to lift my foot and I wouldn't even have to think. These are so quick as they are automatic, and the message does not need to travel to the brain for interpretation. Okay, so this is a slide showing the overview of the nervous system. So we can see in the pink box that the central nervous system is made up of the brain and the spinal cord, and this is the communicating centre. The blue box describes the peripheral nervous system that is made up of all the nerves outside the brain and spinal cord. We can see that the central nervous system communicates with the peripheral nervous system. And then if you move down the diagram, you can see in the pale blue box, we have sensory nerves. The sensory nerves send information from our body to the central nervous system. And then to the right, we have the motor division. So the motor nerves, these motor nerves send information down from the brain and spinal cord and out to the rest of our body. The motor division is further divided into two separate branches. So we have the somatic nervous system, the blue box to the right. This is under our voluntary control. So it enables us to contract our muscles and to move. And then you can see to the left, the pale purple box, the autonomic nervous system. This controls involuntary responses. So for example, messages to our heart to enable it to contract. All these sort of automatic responses that we don't even have to think about are controlled by the autonomic nervous system. This further divides into the sympathetic division. So this is our flight or fight response. So it enables our body to prepare for whether we're going to run away as quickly as we can or whether we're going to fight that scary monster that's come in front of us. So it will start making our heart pump faster, tense up our muscles to enable us to defend ourselves, or the blood will rush to our muscles to enable us to run away as quickly as we can. And then the last section of the autonomic nervous system is the parasympathetic division. And this enables us to conserve energy and enables us to be able to rest and digest. So I'm just going to show you a short video now.
So this video is just going to cover what we expect typical development to be like in the first year. So it's just useful for you to have an understanding of what typical development is in order to then understand atypical development.
When a baby is born, he is a helpless creature with very little motor control. But by his first birthday, he is a mobile, independent toddler. So what happens in between? Let's briefly explore gross motor milestones in the first year of life. The newborn has spent 9 months tightly packaged in the mother's womb, and posture is dominated by physiological flexion. The infant's spine is curved and the limbs are flexed and held close to the body. Many movements and postures at this age are reflexive. On his tummy, the baby's arms and legs are flexed up under the body, with the weight shifted forward onto the chest, neck, and head. He has little to no head control and may be able to extend his neck just enough to drag his face from side to side. In sitting, the baby has no trunk control and requires full support. He bobs his unsupported head and may hold it upright momentarily at best. When placed in a standing position, the newborn may reflexively bear weight on the legs and will sometimes even take some reflexive steps forward. After 3 months of moving in a world with gravity and hopefully lots of tummy time, physiological flexion has diminished and the baby now has strength to extend his head, neck, and trunk. The 3-month-old can shift his weight back onto his lower trunk and pelvis and lift his head completely upright to 90 degrees and prop up on his elbows when placed on his tummy. On his back, the baby is able to keep his head in midline and may bring his hands together or even put them in his mouth. In a supported sitting position, the baby can lift his head and neck, keeping them upright and in midline, but he is unable to sit independently for any length of time. Reflexive standing and stepping have disappeared, and the infant may not bear any weight when caregivers attempt to place him in a supported standing position. By 6 months, the baby has gained trunk control and is able to sit independently when placed. He is still a bit unsteady when sitting and may fall after a few seconds. He probably cannot yet use his hands to play with a toy in sitting or move in and out of a sitting position on his own. On his tummy, the baby will lift his head and bear weight on extended arms, raising his chest, head, and neck off the surface. He may come to a hands and knees position and even rock back and forth, but he is probably not yet creeping or crawling forward. On his back, the baby now has sufficient abdominal strength to curl his trunk, lift his pelvis, and grab his feet and toes. He is now able to roll from his tummy to his back and can probably roll from his back to his tummy as well. At this age, the baby's legs are strong enough to support his body, and he can stand with his hands held, but he is probably not yet attempting to take any steps. By 9 months, most babies have achieved some sort of independent mobility, whether it be rolling across the room, army crawling, or creeping on hands and knees. No matter what movement solution he has found, the baby can now actively explore his world. The infant has now gained control of his lower trunk, pelvis, and hips. He sits well, can move in and out of a sitting position, and pulls himself to standing at a stable surface such as the couch or living room coffee table. At this age, most babies can take steps with their hands held, and some have begun to cruise by stepping side to side while holding a stable surface. More precocious infants may begin to let go and stand independently for a few seconds, or even take a few early unsteady steps. By the first birthday, most babies have taken their very first steps. However, creeping or crawling may still be the primary means of mobility, especially when baby wants to get somewhere fast or is in a new or uncertain environment. And some babies are still holding on and don't take their first steps for another month or 2 or more after their first birthday. More adventurous babies may be attempting to crawl upstairs or climb onto low stools or low furniture. Babies with more advanced motor skills may attempt to squat and will begin to practice lowering themselves with control and returning to standing without falling down. Please keep in mind that while this video presents average ages when children reach selected motor milestones, every child develops at his or her own rate and in his or her own way. Development can be heavily influenced by individual differences in the child or external factors such as the child's environment or culture. It is much more important to compare a child to himself when assessing his gross motor development over time, rather than comparing him to what is, quote, normal. As long as a child is developing and making gross motor gains, he is probably gaining skills at a rate that is just right for him. Gross motor milestones are just one small piece of the developmental puzzle.
Excellent. Okay, so hopefully you found that interesting and can maybe have a think about some of the young people that you work with in regards to sort of where their development may have reached. So to move on, just to summarise some of the bits about typical development, it's really dependent on having a normally developed central and peripheral nervous system. So the elements of your nervous system that Emma talked about start developing from the moment of conception, and typical development of that is really key. So anything that affects that development en route can affect outcomes for people. As we've said, the experience of development starts in utero as soon as you're conceived, and it's massively variable amongst individuals. So I'm sure watching that video you may have compared it to any children that you have yourself or you know, and everybody sort of walks at different stages or learns their skills at different stages, but there's a general sort of spectrum along which we develop. But if you think about sort of Usain Bolt is very different in regards to his running capabilities to myself, and everybody, even as adults, varies significantly on their development and their skills. But it's significantly dependent on your environment as well as your makeup of your central and your peripheral nervous system. So an example of this is that there can be children who have perfectly intact normal central and peripheral nervous systems but haven't had the opportunity to develop skills and typically develop. An example of this is where I've worked before on intensive cares, where children have come in, they've had a normal pregnancy, normal delivery, but then have an issue with their bowel or their gut, for example, and require surgery. They're then not able to lie on their tummy following that surgery. They're not able to move about and interact with parents and siblings and their environment in quite the same way. So a level of delay in reaching motor milestones can occur due to just the environment and the experiences that that child has undercome. The limits of what we would call normal development are vast. As we've said, we're all very, very different, and the way in which children develop and sort of our ballpark of where we'd expect motor milestones can vary quite significantly. But it all comes back to overcoming gravity. So a lot of the positions that children learn use skills in, such as laying on your tummy, are all learning to lift your head up against gravity, learning to lift your arms up against gravity, and developing that, that muscle power up against gravity. And our development can progress into and during adulthood. We learn rapidly as children. We lay down neurological pathways really rapidly as children, but we're neuroplastic, which means that you can learn and build new motor pathways, new neurological pathways in our brain and our nervous systems, and until we die. So if I wanted to take up the violin age 60, I'm sure I've still got capacity to learn it to a level. I might not be in the in an orchestra, but you can still learn things in your adult life. So it's important that we recognise that development can continue into adulthood. So now we're going to talk a little bit about reflexes and how reflexes can have an impact on some of the young people that we work with and within our working environment and even in ourselves. So we all have reflexes. They're involuntary actions originating from the central nervous system. So if somebody sneaks up on you and makes you jump, we still have that startle reflex. So they exist in all of us. They're protective and nurturing in nature. So reflexes that we have as an infant are to help us survive. And even now we still have a lot of the reflexes that come from sort of your fight and flight response. So reflexes can respond to specific stimuli, and they're part of typical brain development. So what we're going to talk about are a little bit of your primitive reflexes. So by that we mean reflexes that you have from birth or they develop in utero, and these are usually integrated into the central nervous system as we mature. And what we mean by that is that we find a better way to manage things. So, for example, come into the startle reflex, which we'll talk about a little bit more. Babies do a massive big startle, but us as adults, we have a bit more control on that. And some of the reflexes we'll talk about are learning balance reactions. And then once we learn those balance reactions, we don't need that reflex in quite the same way. But in atypical brain development, some of these reflexes might not get integrated and then can be problematic for some of the young people that we work with. And also reflexes that have been integrated can become unintegrated if the brain is injured, such as a brain injury, a trauma, or a stroke. And as any other neurological pathology can cause some unintegration of these reflexes. But what we are aware of is that often reflexes can be mistaken for challenging behaviours. So there are some movement patterns in young people that are reflexive or due to their underlying neurological impairments that actually may look like challenging behaviours. And that's what we need to start being aware of and recognising to manage. So we're going to go through a few of the reflexes that you may commonly see. You may not have come across any of these, but they may ring true with some of the young people that you work with. So the first one we're going to talk about is your palmar grasp reflex, and some people call it grandma's squeeze. I'm sure you've all seen this with newborn babies. You put your hand in the middle of their palm and they close their hands around you and everyone goes, oh, they love me, it's great, they're holding my hand. It's a reflex, but it starts around 16 weeks in utero. So at 16 weeks pregnant, this reflex is starting to be present, and it's usually gone by about 3 to 6 months. So the literature varies on this, but it should usually be fully gone by about 6 months. But if this reflex is unintegrated, it can be problematic for a child who's 9, 10, 11, and you give them a spoon or a pen to hold and they're not able to let go of it. So this can sometimes be seen as behavioural. The child doesn't want to give the spoon back, but actually it may well be that that reflex that's causing them to grasp is switched on, and it's really hard for them to release those muscles. So you can look at stroking the back of the child's hand to see if that can stimulate the muscles on the other side to release the spoon. Children tend to start to unintegrate this reflex. You'll see kids will hold on to things and suddenly drop them, and then you'll pick it up, you give it back to them, they'll hold on to it and they'll drop it. And that's these children learning to overcome this reflex. But then it becomes a bit of a learned behaviour, a bit of a game. So then you'll see older children that are doing this as a game as well. So reflexes, again, looking at your plantar grasp reflex, this is the same as the one in your hand, but for toes. So if on a newborn baby you touch your thumb onto the bottom of their toes should curl around. This is usually gone by about 9 months, in time for children to start walking. If it's not integrated, or it's integrated late, this can really affect getting up onto your feet. And in children where it's not integrated, you can sometimes have problems getting shoes on. So again, this may be seen as behavioural, that children, as you put their shoes on, are curling their toes up as they don't want their shoes on. But actually it may well be this reflex. So looking at making sure you know where the trigger area is for this reflex, opening up shoes wide, trying to put the whole foot flat into the shoe rather than pushing on that ball of the foot that's going to stimulate this reflex. So we're getting there through the reflexes. So this is the rooting reflex, which is where children are looking for milk. So if you stroke the side of a child's mouth, they will turn their head to that side. They're looking for milk, they're looking for the nipple, they're looking for the bottle teat. And this is usually gone by about 4 months, when children sort of learn what feeding is all about a little bit more. This was seen by a colleague of ours where this reflex was constantly being stimulated as a child was turning their head in class the whole time, but actually they realised that the shoulder strap of the wheelchair was stimulating this reflex, and it was really distracting for the child who's trying to look forward and pay attention to class, but having this reflex overstimulated. Again, it's one to be mindful of when putting clothes on, if this is still quite an unintegrated strong reflex for a child. Anything that brushes the cheek can potentially prompt this reflex. So this is known as the fencing reflex. It's got a posh long name of the asymmetrical tonic neck reflex, or ATNR, it's often called. And this is all to do with development of the inner ear. So a child, if they are tilted slightly, will go into this posture with their upper limbs and will bend one leg up on one side. This stops them rolling over onto their tummy as a newborn, where they aren't able to lift their head at this age to breathe. This is usually gone about 4 months of age, when the child has better head control and they found a better way to manage. But if this is unintegrated, it can cause quite a lot of issues with two-handed activities. So any midline activities, And also asymmetry can affect your musculoskeletal system, which we'll talk about later. So it can subsequently have more of a long-term effect on balance and hand-eye coordination, even if this reflex is diminished. If it's still there slightly and triggered with a rolling mechanism for the children, it can be problematic. It can also be seen as children turning away from the spoon or resisting any rolling activities. So just needs to be, we can't change reflexes, but we can work with them. So we just need to allow a little bit of consideration as to how we manage. So this one, again, has a long name, the tonic labyrinth reflex. And this is an extensor pattern which assists with overcoming gravity. So if you think about, so wearing like an Alice band across your head, if you carry on that line from that Alice band down through your head, through your shoulders, if in a child you tip their head beyond that line, so tipping forward, they will come into the flex position as shown in the bottom picture. And if head is tipped backwards, arms will go back and they'll go into that sort of a high guard position. And this is all about developing head control and posture stability. So children learn actually if they go far past that line, they'll flex, and the other way they'll extend. And it works with other reflexes to start developing postural control. And usually when children have developed all their postural control together, this reflex tends to be starting to integrate. So usually by about 3, this is all completely gone. But if you don't get this development of posture control muscles and this reflex is still present, it can be really fatiguing just sitting, that these children are constantly having to overcome this reflex. So some considerations could be the position that we're putting the chairs in, if you're going through any thresholds, through any doorways, or suddenly changing the tilting space on a child's chair, just being considerate that actually what's their head position, are we going to trigger this reflex, how fatiguing can that be for that child. So just a few considerations around that. And then we're nearly there on reflexes. I think we've got about 3 more. This is the startle reflex that you've probably all seen, the baby sleeping nice and quietly in the corner, door slams, they go into this position you can see in the picture, which can be triggered by sudden head movement or unexpected noise. And they startle and then can settle back down. If this isn't integrated, this can be quite problematic for children in the classrooms. If you're constantly startling, that can be really exhausting. Just think about the times when you've probably gone through a haunted house yourself and you startle, you get to the end, you're exhausted. If children do still have quite a prominent startle reflex, we need to think a little bit about classroom strategies to lessen the impact of this. So think about when you're doing tasks with children, what else is going on in the class? Where are other children who may be a bit more noisy or doors slamming? Just need to have some consideration about some of the activities that you're doing if a child is really prone to startle. We do still startle as adults, but it's not the full restricting physical response that you can have if this reflex hasn't been sort of dampened down or integrated. So now we're going to talk about biomechanics. So this is basically the mechanics of how we move, how muscles influence our skeleton, how we're held together really. So we're coming away from the central nervous system a little bit, but we will keep in mind that our central nervous system governs how our musculoskeletal system works. So just to start with, we're going to talk a little bit about how we're held together. So you've probably come across the terms ligaments, muscles and bones. So ligaments are our stabilizers. So as you can see from this picture, they're the white fibrous bands. We have these crossing all our joints to give a level of stability to the joints. So they're fibrous bands that are fairly rigid. Then looking at tendons, tendons are, you can see at the bottom here, I don't know if my arrow is coming up, these are the anchoring points where the muscles attach into the bone. And then we have what we call our skeletal muscle, which contracts and relaxes to make movement. and got these throughout our body. We're going to talk about skeletal muscles, which are muscles that are under voluntary control. We do have non-skeletal muscles, such as your cardiac muscles and your respiratory muscles, which aren't under our conscious control, but we're not going to be talking about them in the same detail. So there's a relationship between all of our muscles, tendons, bones, and they create a pulley system in our body that creates our movement. So if you're getting a normal muscle pull, you're going to be getting normal development. So if we talk about the biomechanical relationship, we're assuming that we're getting normal muscle reaction, and this is dependent on having normal messages sent from our central and peripheral nervous systems. So if we're getting altered muscles, we're going to get altered muscle movement. So you may find it useful if you put your hand on your arm, put your hand on your bicep and your tricep round the top of your arm. If you then bend your arm up, you will feel your bicep contract, which is working as a pulley and moves your bone that is the lever. But at the same time, your tricep, your muscle on the back, will lengthen. And it's this reciprocal movement that needs to happen for muscles to work well and to influence our bones and our movement. So when one set of muscles or one muscle shortens, the others need to lengthen to control that movement. So that's what we said before, the muscles act as a pulley and the bone acts as a lever. So without this, what we call reciprocal movement, you're not going to get quality movement, and that can impact our overall outcome of movement. But in children, it can influence how our bones develop and potentially influence deformity. So if one muscle is always on, we can get tightening and shortening of that muscle. And if we don't work in a reciprocal pattern, you can have abnormal strains and pulls on the bone. Now, this is really important in a growing child. So our bones are alive and modelled all of our lives. So if we get a fracture, our bones heal really well with new bone tissue. The muscle action molds the bones as we grow. So you can see this is an x-ray of a young child, and you can see it looks like they don't have a head to their thigh bone, a head to their femur, but they do. They have a little, what we call an ossific nucleus, but the rest of the bone head, the head of the bone is there, but it's all in a cartilaginous form. So if you were to see an x-ray of a baby, it looks like they don't really have that many bones, but actually they're all quite soft, moldable cartilage at that stage. And then as we grow older, our bones ossify more and become more solid bone. But the bone development influences muscle pull and vice versa. So if you have normal biomechanics and normal muscle pull that we've spoken about, you're going to get a typical bone and joint development. Now, the best way I can show you that if we get an abnormal pull is to just stop screen sharing this presentation for a moment and just show you using my hand. So I'm just going to bring it back to video, so just bear with me one moment. So if you think about your hip being a ball and a socket, so this is the ball and this is the socket that your hip sits in. If you have normal movement of your hip, it's moving nicely, you've got nice reciprocal movement, you are going to mold the head of your femur into a nice round shape. So imagine as a child, this is very much made of cartilage, and it's like Play-Doh. You mold something round into something round, it becomes round. But if, say, for example, you've got abnormal pull of your muscles, so this one being your thigh bone, if that's constantly pulling across into a cross-legged position, it's going to affect how the socket of the hip forms. So then having a shallower socket rather than a round socket, because your muscle pull is putting your bones here, these children are going to end up with flatter heads on their femurs and actually going to be getting more of a flatter socket as well, which then subsequently can cause what we know as hip migration, where the hips generally aren't sitting in position and the hip is less stable. And this on the long term can end up causing pain for children and ultimately need further management. So we monitor hip position and development really well, because it's really important in children more than adults, because it can actually directly influence how the bones are molded. So just one last little point which links in quite nicely with that is, are kids little adults? No, essentially they grow, and as we've said, bone makeup is a little bit different. It's more soft and cartilage and moldable, and we have the influence of growth, trying to lengthen muscles and lengthen bones, alongside any abnormal neurology, can cause areas that are muscle that are tightening. So children may have skills when they have little skeletons, so they may be able to sit up when they're little, but as they get a bigger skeleton, heavier muscles, and have to overcome gravity even more as their skeleton changes, actually it can result in sort of a loss of skills because they have a bigger skeleton to move around, and any limitations that have come from a biomechanical point of view, as we've just sort of discussed. So growth is always a factor. And some things are normal for age as well. So things that are not normal for adults are quite normal for children. Children are a lot more mobile. We can't get our feet into our mouths as adults. Some people may be able to, but babies can. In-toeing is a normal stage that young children go through. And same with being a little bit knock-kneed and bow-legs in early infancy. Again, are stages that children go through and are normal variants for children, but not so much as they get older. So these are all things that we do need to bear in mind. And also in the general population, the types of injury that you might get from a fall are going to be different, or from a sporting injury are going to be different for an adult with a matured system of biomechanics compared to a child where everything's softer, bones haven't formed and things in the same way. So the type of fractures you get as a child are different to the ones you get as an adult, for example.
So we're going to have a look at muscle tone now. Muscle tone can be defined as the level of readiness in a muscle. So we all obviously have muscle tone. This helps us to sit upright, helps us to be able to move around our environment. I suppose the key thing with muscle tone is it does fluctuate. It fluctuates from low to high. And as physiotherapists, we work with children with varying different types of muscle tone. And when we start working with children, we look at ways to try to either increase their muscle tone if they have low tone, or if they suffer from high tone, then we look at ways and positioning and stretches to try to help decrease this muscle tone. Muscle tone is dependent on the messages that are sent from the brain. So if you have constant firing of messages, then the muscle tone can be high, whereas if you have less messages being sent, the muscle tone is low. So just looking at these two pictures, just to try and give you an idea about muscle tone. On the left, there's a young boy who's just sort of leaning forwards on his desk. So we'd probably say that his muscle tone looks low. It looks like he's feeling tired and he's just slumped forwards, and he may find it hard to come up against gravity, so to be able to sit himself up. Whereas the boy on the right-hand side, we would say that he looks like he has high muscle tone. You can see from the position of his elbows and his hands that his elbows are what we call flexed, they're bent, and his fingers are also flexed, bent over. So you'd probably imagine if that you were going to move his arm now, for example, to put his coat on, then it might be quite tricky to move his arm because of this high tone. You may feel that you sort of feel a bit of a catch as you're trying to stretch out his arm. So as physios, as I was just saying, we try to help to enable children to reduce this muscle tone so that they can get on with everyday functions and just everyday living, and just to try and make things easier. Just see the pictures in front of you. So again, just thinking about whether the people in the pictures have high tone or low tone in their muscles. So looking at the one on the left, it's a person who obviously looks very, very cold. They're sort of having to put their arms around their bodies, try and warm themselves up. So that would suggest high tone. So they're sort of tensing their muscles to try and get some warmth. Whereas when you look to the picture of the lady lying above the lovely tropical sea, she looks very relaxed. So if you imagine yourself there, hopefully if this picture appeals to you, then you'd probably feel very relaxed and your muscles would feel relaxed, and we would say that they're low tone. We have the emoji screaming. Again, that suggests high tone. And then the last picture is, we're never quite sure about this. We'll sort of leave this down to your own interpretation. So someone's obviously given their toe a big bash and they've got a dressing on it. So are they sitting there all tense and in pain and their tone has gone up high? Or because they've sort of got it stretched out on the dashboard, you may think, oh, they've been to the doctors, they've had some painkillers, they're stretching out now and just enjoying the drive. So maybe their tone is low.
Okay, so we're going to end, this is part 1 of 2 of this level 1 physical development. So just give yourselves 10 minutes away from the screen, have a little bit of a break, and we will come back with the second half soon. Thanks.